Hi, everyone. I'm Dr. Elisa Bronfman, a psychologist from the Family Medical Coping Initiative at Boston Children's Hospital. Thank you so much for joining us. The Family Medical Coping Initiative is a program through the Hale Family Center for Families at Boston Children's Hospital. We're a multidisciplinary effort spearheaded by psychology, which is me, social worker Annie Banks, and child life specialist Gail Windmueller. The program was developed to provide education to families and staff about ways to enhance child and family coping with medical conditions. Within the next week, you will receive an email with a recording of this webinar, and it will also be on the Boston Children's Hospital YouTube channel and on the Family Medical Coping Initiative playlist. We are delighted today to have our colleague, Dr. Rachael Coakley, speaking on the topic of persistent pain, which is a very relevant topic for us in the Family Medical Coping Initiative because pain is a factor in many illnesses. It's distressing to children and caregivers, and addressing pain directly can improve daily life. In addition, building coping skills can have an impact on both health outcomes and life satisfaction for children and families. Dr. Rachael Coakley is a pediatric pain psychology at Children's Hospital, where she serves as a director of clinical innovation and outreach in pain medicine. She's also the founder and director of the Comfortability Program, an internationally shared intervention that teaches evidence pain management to children. She's also been honored with several awards for her program development, including the American Psychological Association National 2020 Carolyn Schroeder Award for Outstanding Clinical Practice. If you want to learn more from her book, When Your Child Hurts, Effective Strategies to Increase Comfort, Reduce Stress, and Break the Cycle of Chronic Pain, won a National Book Award for the Best Parenting Book of the Year. And you can, I'm sure, find that at your local bookstore or order that for yourself. We're delighted to have Dr. Rachael Coakley, and I turn it to you.
Thank you very much, Dr. Bronfman. Delighted, absolutely delighted to be here with everybody. So let's dive in. I'm going to be talking about how to help your child with persistent pain. And before I get started, Dr. Bronfman mentioned my book. I just need to disclose that I do receive royalties from this book, and it's very part and parcel to all of the things we're going to be talking about today. Okay, let me give you a quick overview of what we're going to cover, just so you feel grounded in what we're going to talk about. We'll start off talking about what is pain, because everybody in some ways has had experience with pain. We don't get to live in this world without that, but really understanding what it is important to understanding how to treat it. Then we'll talk about how the body actually produces pain, very important also for knowing what to do about it. We'll talk about the role of psychology in treating pain, which is a little counterintuitive. People sometimes scratch their heads and they wonder, like, why psychology? What does psychology have to do with pain? Pain's a medical problem. But I hope I'll change your mind about that a little bit. And then we're going to talk really concretely about how parents and caregivers can help their kids when they're struggling with pain or discomfort. We'll wrap up by going through some resources that are freely and readily available for everyone, and then I'll protect some time for questions as well. So let's jump in. Let's talk first about what is pain. It's a pretty simple question, but it's really often not what you think. So first of all, what you need to know is that pain is a protective function of our nervous system. It's designed to keep us safe. And pain is both physical and emotional all of the time. You can't separate the two of those things. Importantly, pain can come from real harm to the body, or pain can actually come from perceived harm to the body as well. And the whole point of pain, from the protective side of things, the whole point is to make us pay attention to what's happening, seek help if that's necessary, rest and recover, which is usually how we respond to pain. And sometimes people don't really think about this, but the other purpose of pain is to create a very strong memory trace of what's happened so that you don't do something dangerous again. So if you're walking along outside and you step on a piece of glass, not only does it hurt in the moment, so you know to take care of that, but next time you're going to walk outside, you might think about putting on shoes because you've got this strong memory of last time I was doing this, I got hurt. So it does all of these things. The other thing that's really interesting and unique about pain is that it's only an individual experience. And what I mean by this is that everyone experiences pain differently. In other words, you can never compare one person's pain to another person's pain. So it's completely unique. It's completely subjective. We can't do a lab test to measure how much somebody hurts. In fact, it's really rudimentary, but the most common way to measure pain is to ask somebody like 0 to 10. 0 is no pain, 10 is the worst you can imagine. What number are you? Which, given all of our medical knowledge and where science has evolved to, it's pretty rudimentary that that's still how we ask it, but it's all we've got. It's really one of the best ways that we know. We have to ask people. And we have to believe them because, you could look at these pictures on the screen and any one of these kids could have 10 out of 10 pain and you wouldn't know it necessarily. Or some of them they might look like they're in pain and they don't have any pain. Like you can't tell often from looking at somebody how much they hurt. It's completely individual. And what else complicates it? I mentioned that we don't have tests for it, but it's not always visible. So let me give you an example. When you've got acute pain, you can usually see it. Acute pain is pain that is caused by an injury, an illness, or a surgery. It's protective, like I talked about. It's supposed to keep you safe. And the way acute pain works is that it hurts until it heals. When the body has healed, the pain goes away. So when we talk about the healing time frame, we're usually talking about less than 3 months. So acute pain caused by an injury to the body or a harm to the body, and usually gets better with rest and recovery up to about 3 months. Often medications are used, often like in the case of this ankle, broken bone, and, needs a rod and screws to stabilize. And when that bone has healed, the rod and screws will come out, the body will be back to normal functioning. You can see this pain. You can understand what has happened because there's a harm to the body. Chronic pain, whole different ball of wax. So chronic pain is pain that lasts for more than 3 months by definition, 3 months or longer. And it's usually what we call non-protective pain. And what we mean by that is that the bones, the tissues, the tendons of the body in chronic pain have usually healed as much as they're going to heal, and they're not in harm. The body's not recovering or healing from an injury anymore. It hurts, definitely. Chronic pain is real pain, but it's usually not dangerous pain. And it can be triggered by acute pain. So chronic pain could come from an ankle injury, like you see with the acute pain. Maybe the bone has healed and 3 months later, but there's still ongoing pain. It doesn't mean that the bone's not good. The bone could be great and still it could hurt. And it often feels the same as acute pain. So people think there must be something wrong still because it still hurts. One really important distinction that I like to make between this term chronic that we use when we talk about persistent pain, and that's this. Chronic does not mean forever. Some things in pediatrics, when we label them chronic, we mean lifelong. This is going to be an ongoing chronic problem. That's not what we mean when we're talking about chronic pain. Chronic pain means just pain that's lasted more than 3 months or and beyond what we would expect for a healing time. And it does get better. For most kids, we see chronic pain get better. So it's really important. It's also important to know that it is really common. 1 out of every 4 kids will have an episode of chronic pain lasting 3 months or more before reaching adulthood. So this makes chronic pain one of the most common problems in pediatrics. And you might be scratching your head a little bit. Lots of times parents that have kids with persistent pain feel like they are completely alone in this and that they don't know anybody else. We're talking about, when we're talking about chronic pain, we're talking about headache pain, abdominal pain, musculoskeletal pain, joint pain, neuropathic pain. When we look across all of these things, all of these areas of pain, this is where we get these numbers, like 20 to 25% of kids have these problems. And the reason it's under-recognized, I think, is that it's usually been looked at in silos. So neurologists look at headache pain, GI doctors look at abdominal pain. And we look in pain, we look across all the pains. So when we gather them all together and we look collectively, that's when we get these really big numbers. So pain is really common. Pain is really, really common. Of the kids that struggle with persistent pain, about 5% are what we call functionally disabled. It's the clinical term for it. And what I mean by that is they really can't function in their day-to-day. They are not going to school, they're not sleeping well, they're not engaged with their activities, maybe they're not seeing their friends. So their life has kind of come to a screeching halt. And that's what we mean by functionally disabled. The other thing that's really important when we're talking about pediatric pain is we have to think about parents and caregivers here as well. It doesn't just affect kids. This is a really sticky problem. Most parents, 75%, report they don't even know how to help their kids. They don't know what to do. They feel adrift. They're just lost. And if that's you, you're in really good company. This is a very complicated problem. And so it's, and like I'm going to talk about in a few minutes, some of how we approach and treat this isn't intuitive. So it makes good sense that parents would be confused. But finding these answers, like figuring out what to do about this, that's super tricky. And often parents say, we went to, they've got these really long, complex pain journeys. And sometimes they're really heartbreaking. They've been to their pediatrician, they've been to multiple specialists, they've had all the tests, and they feel like they haven't gotten the answers to start to get things back on track. All of this searching is really costly and can take months, if not years. And so it can be a really frustrating and challenging problem to treat. And so we have to really think about what can we do to arm parents with the skills and strategies that they need to support their kids. And sometimes, sometimes this journey, this visiting all of these specialists and all of this testing has to be done, right? We have to understand the biomedical underpinnings of pain. But we also have to know that there are things that we can do even while we're in that holding pattern that can help kids to be more comfortable. And I'm going to talk about that. Now, when we talk about how does the body produce pain? So far we know it's a really individual experience. We understand that chronic pain or persistent pain is supposed to be protective. And we know that it's a really common and complex problem. Let me see if I can break down for you a little bit about why that is. Pain is what we call biopsychosocial, which is a little bit of a mouthful, but what it means is this. Pain, the experience of pain, sits in the middle of biological factors, illness, injury, genetics, hormones, all of that, and psychological factors. Oops, let me pull these up as well. Mood, worry, stress, anxiety, trauma history, things like that, and the social environment, friends, family, home, culture, and community. And pain sits right in the middle there. You can also think about the fact that comfort sits right in the middle there too. And I'm going to sort of show you about that a little bit. But what we know neurobiologically is that at the center, at where all of the biology, psychology, and social environment overlap, we have things that can wind up our nervous system and increase pain. Let's say stress or anxiety, those are wind up factors. They increase our sensitivity neurobiologically to pain. But we also know that there are factors that can wind down the nervous system and decrease it. And the reason this is true is because pain comes from your brain. It doesn't come from the actual bones or tendons or tissues that are in your body. Let me walk you through this to make sense of it. Okay, let's imagine in this picture here that this is a kid who's got chronic back pain. Maybe they had a sport injury a while ago, but now they've just got this nagging pain in their back and they can't get rid of it. Here's what's happening inside the body. So what you see highlighted in this number 1 area here, these are little tiny nerve endings. And their job in the body is to pick up a chemical message that is kind of like a danger signal or a warning signal. You can think of it that way. So they sense something's going on. They do not pick up pain. They just pick up something's going on in this area of the body. Don't know what it is yet. And what they do is they start a transmission. I like to think of it like our little nerve endings when they carry this danger or warning signal. I think of it like passing a baton from neuron to neuron. So the transmission goes from these little tiny fibers into the spinal cord, which is part of your central nervous system, and it fast tracks right up to the brain. And when the brain gets these messages, it has to decode them. Now, what's really cool about this is that there are some parts of your brain that are super specialized and they only do one thing. Like you may or may not, like your vision, for example, is one of those areas. You've got a whole part in the back of your head that only does vision. That's the only thing it does. You've got a part of your brain sits right up here on the top of your brain. It only does motor. All your muscle movements come from there. There's no such thing as far as pain is concerned. And because pain is this biopsychosocial problem. And so what happens from the pain side is what's called, the pain is decoded by what's called the pain neuromatrix, which is a fancy way of saying your brain looks at your mood in the moment. How are you feeling? Are you happy? Are you fearful? Are you depressed? It looks at how much anxiety you have about the moment, like what's going on with my back? What could this be? Something must be wrong. All of those thoughts, past memories. Has this been a problem for me before? What could it mean for me? How much you're focused on it. Are you paying attention to it right now? Or are you distracted doing something you really love, like hanging out with friends? Or are you just sitting alone in your room thinking about it? Do you know the planning centers of your brain? Do you know what to do about it? Do you have a plan for managing this hurt? Whether it's going for a walk or stretching or learning how to relax, whatever it is, do you know what to do? And all of these things come into play. So your brain filters, all of this together. And this is what's called the pain neuromatrix. Everybody's got one in their brain. It's this mashup of all of these areas. Your brain decodes it. And then when it figures out what could be happening, it sends a message back down through the spinal cord to those little tiny nerves that started this warning signal in the first place. And that is what you feel as pain. So you might hear people say pain comes from the brain, pain is modulated by the brain. And I wanted to sort of unpack this so you understood what it means. Sometimes this is misinterpreted as pain is in your head. It's not in your head. Pain is real and it always comes from the brain. Both of those things are true. The pain you experience in whatever might be going on is real pain, but it is modulated by your brain. Now, kids need to understand this too. And so I have a couple of metaphors I want to share with you that are kind of nice ways to explain this to kids because that's a lot to take in. That can be really confusing and hard to understand. But it's really essential for kids to be able to understand what's happening in their body so that they don't feel as fearful, so that they know that they can come up with a plan and there are things that can be done. So let me just walk you through 3 of my fave metaphors for this. One of them is this idea that your brain is on high alert. Our brains are always looking out for pain because remember, pain's protective, so we're supposed to be careful. But so your brain's on high alert, sending a fire alarm. But we know, we've seen smart doctors, we've had lots of tests done. We know there is no fire right now. There's no back injury that's persisting. So now we need an approach to turn off the alarm. We're not worried about an injury to the back anymore. We just have to get the pain alarm to stop ringing and sending this protective signal. It's really good news. And there are ways that we know how to do this. Another metaphor I like is this idea that your body is like a computer and it's having a problem running a new program. And you probably know when your computer is not working, you might check the hardware first, right? Like, is it plugged in? Is the keyboard working? All of those things. If the computer is not broken, if it's not hardware in the computer, then it's a software glitch. And when you've got a software problem with your computer, you have to restart your computer. Maybe you shut it all the way down or you Control Alt Delete. However you reboot, it refreshes the software. And chronic pain is like that too. So the software, which is the communication between the brain and the body, what we call the brain-body connection, is the software in your body. And that is what needs a reboot when we've got chronic pain. So that's one way. And the last metaphor I'll share, which is sort of like trying to understand how did we get here, right? Like, why would your body produce this persistent pain? Because, okay, you can maybe understand that pain is protective and acute pain protects you, but chronic pain usually isn't. Chronic pain's just interfering with life and making kids feel really anxious and sad, and parents too. But the reason you get to this place is because your brain is like a learning machine. It's built to learn. That's what our brains do. And you can explain that like learning to read was hard at first for most people, for kids, but then it gets easier with time because your brain learns. Well, with chronic pain, it's kind of the same thing. It's like your brain has learned how to persistently produce this danger signal, this warning signal, and it practices it so much, it gets good at it. And that's not good, right? Like we need it to unlearn its response to pain. The good news is we know how to do that. We know how to unlearn these things. So that's really important. So let's talk for a couple of minutes about what the role of psychology is in treating persistent pain, because this is where people start scratching their heads a little bit, but hopefully I've got my foot in the door a little bit. Now that you understand it's biopsychosocial, that the pain comes from the pain neuromatrix in the brain, which is a mashup of all of these areas of the brain, including things like mood and attention and planning. And that's the wheelhouse of psychology. So let's unpack this a little bit. Okay. If you've got a kid with persistent pain, you definitely don't need me to tell you that the impact of this is significant. Just to ground you and understanding, you understand now that really, really common, but of the group of kids, of that 25% of kids that have persistent pain, most of them, 80%, struggle with sleeping, either falling asleep or staying asleep, sleeping too much, not sleeping enough. Most of them, depending on where you look in the research literature, 50 to 90% struggle with school, either memory or concentration, or they're not going to school, or they're coming home early, or too many doctor's appointments are interfering, grades are dropping, whatever it might be. Kids with persistent pain are 2 to 3 times more likely to develop anxiety and depression. Than kids without persistent pain. That's really important because pain triggers your fear response center in your brain. Part of that neuromatrix, it's designed to ping that part of your brain. And so it makes sense that kids become anxious when they've got persistent pain. But also, I just want to add, if you're a kid with anxiety or depression before you've got chronic pain, that's what we call a vulnerability factor. That sets you up for chronic pain to walk in and get seated. So it becomes really important because we can't just treat one or the other. We have to treat the whole person, which means treating the symptoms that go along with the pain. It is true that kids that have ongoing pain, if it's not treated, have long-term risk for disability associated with it if it's not treated. But if it is treated, and we're going to talk about treatment models, kids tend to do really well with it. And of course, we're always mindful of the risk for medication overuse. There's a very important role for pain analgesics and medications like opioids that are used for acute pain very important, very powerful medications, but they're not used for treating chronic pain. And we want to make sure that we're shifting when we understand what the problem is. One of the ways that again, I'm going to give you another metaphor because I like to explain things in ways that make it easy to understand because pain is messy. So let's explain this, what's called the multidisciplinary approach. And the way I explain this is I like kids to think about the fact, and parents too, that when you've got persistent pain, you're like a tricycle with 3 flat tires and like broken down on the side of the road. You're just stuck, really, really stuck. And to get going again, you have to fill all of the tires. And the way that we fill it, our multidisciplinary approach to treating pain usually includes, it says medication on here, but I like to think about it as recommendations from a physician. So you've got to have a physician on your team, so that somebody that you trust that can give you recommendations. And sometimes the recommendations from your physician are do the psychology and the physical therapy. That might be it. But sometimes there are interventions specific from a physician that are also part and parcel to the treatment plan. One tire is filled with the skills and tools that come from psychology, and another tire is filled with physical activity. So that's very counterintuitive. I get it, because when you hurt, you don't feel like moving. But part of how we undo this cycle of persistent pain is to get kids moving again, even sometimes when they hurt. If you don't fill all the tires, it can be really hard to get going again. And you can just kind of imagine that. If you're a trike and you've only got 2 tires filled, you kind of might like lopsided, like spin in circles, but you don't really get back on the path and move forward. So I really like to, for people to understand that this is never a one pill solution. It's never a one psychology skills solution. It's never just a one thing. What we want is a combined or synergistic approach. With that sort of combined approach of all of them together is where we really start to see things move forward. And from the psychology end, we root ourselves in what's called cognitive behavioral therapy. If you have been a part of this amazing lecture series before, then you know a little bit about CBT. But for those of you that might be new to it, real quickly, CBT is an evidence-based type of psychotherapy, and it focuses on identifying problems, learning concrete skills to address them, and then tracking improvement. One of the hallmarks of CBT is the connection it makes between what you think, how you feel or your emotions, and your actions or behaviors, because all of those things are always linked. And it's science-backed. So we're going to root ourselves in the evidence base in the research literature so that we know that we've got a strong anchor in the work that we're doing from psychology. So how does it help with pain management? Well, the research tells us it reduces pain, so good news, but also lowers stress, improves daily function, reduces symptoms of anxiety and depression, so those comorbidities that go along with it. And importantly, it improves self-efficacy. This is really like, this is definitely a psych term, self-efficacy, but real simply, it's the belief that this is a manageable problem and that you have something that you can do about it. And remember the planning centers of the brain? Well, it turns out that belief that you know what you can do in the face of an ongoing problem with pain, even all by itself, that predicts better outcomes. So if we can help kids and parents to know that this is a manageable problem, right off the bat, we're making progress. But let me try to be a little bit more specific here and explain the skills that come from psychology. So think for a minute. I'm throwing another metaphor at you. Here we go. Stay with me. Think for a minute about your nervous system being like the electrical wiring of a house. So just imagine filled with nerves, and all of those nerves throughout your body are like electrical wiring. Well, one group of the skills that we use from psychology, I think of like dimmer switches. And these are designed to decrease pain sensitivity. I think of them as the wind down strategies. We talked about what winds up the nervous system and what winds it down. These dimmer switches are the wind down strategies. So these include relaxation-based strategies like deep breathing, guided imagery, mindfulness, and biofeedback. Those are all dimmer switches. So you can just imagine dialing back all of the electrical energy in the house. Again, I just want to pause for 1 second to say that these relaxation interventions lead to what's called the relaxation response, which some of you may have heard of before. It's a term that's been around really since the 1970s. But the relaxation response is very different from rest. So sometimes we get teens and we start talking to them about relaxation and how this is so critical as a wind down strategy. And they're like, yeah, I relax all the time. I'm texting with my friends, I'm playing video games. It's totally relaxing. That's rest. Rest is sometimes important in recovery phases as well, but rest and the relaxation response are not the same thing. The relaxation response is a very specific wind down for the nervous system that creates a sense of calm and well-being throughout nerves and the brain, central nervous system, and all the peripheral nerves. And it's part of how we reset that computer glitch. So it's really an important distinction for parents and kids to be aware of. We're not just talking about sitting on the couch. We're talking about active relaxation that triggers the relaxation response. That's the dimmer switch. Okay, that's group number 1. The second group of skills and strategies, I think of like circuit breakers. So these are behavior changes that we want kids to make that are designed to sort of break the habit cycle that can get into place when there's persistent pain. So let me give you an example. It's not uncommon for kids that hurt to not sleep well at night and then want to sleep late in the morning, or maybe take naps throughout the day. That becomes a habit cycle. So the more you sleep late, the more naps that you take, the more you can't sleep at night, and on it goes. Well, often kids think you have to get rid of the pain so that I can sleep better at night, and that will reset things for me. And unfortunately, that's not the way it works. So part of how we reset the pain is to use proven behavioral strategies to reset the sleep. And when we get kids sleeping better, it's one of the things that helps the persistent pain to get better. So I think about these as like, let's break the circuit, let's break those habit cycles that get put into place. So we're talking about sleep patterns, we're talking about activity day to day, we're talking about return to school plans, all of these behavior strategies. This isn't easy work. This can be some heavy lifting because especially if pain's been around for a long time, you have to start small with these little bite-sized pieces to break these habit cycles. And sometimes our starting points are so small that people are like, this can't make any difference. This isn't going to matter. But it's how we start to get things reversed in the other direction. And so we use our behavior strategies to do that. A couple tips here specific for our parents. So I want to say, okay, so now we understand CBT is important, but what's the role of parents? Okay, there's quite a lot that parents can do to help their kids with pain. So one thing is helping or supporting kids in practicing this relaxation response. And at the end in a minute here, when I go through some resources, I'm going to show you on our webpage, we have a really lovely video of a parent who is not a psychologist, who is just a parent with no background in relaxation skills training, reading a script, working with her son, trying to sort of help create this relaxation response. And so parents have a really important and helpful role to play from this perspective. So here's some tips for parents who might be thinking, yeah, that's something we haven't tried and we'd be willing to explore. So first off, learn these skills yourself. If they're new to you, you might need a little time to practice on your own just to get a sense for what it feels like. I always suggest that you start a relaxation practice with your child when pain is low to moderate. So we don't want to wait until we've got a pain flare or 10 out of 10 pain to say now's the time to try to implement. When you practice when pain is lower, you start building confidence. And then, of course, it can be applied when pain is worse, but try to find a time when things are relatively calm to try. And provide a lot of positive support. This is hard work for kids, and it might feel awkward for them. Just put that out there. Be real, like maybe it feels weird, maybe it feels strange, but give some positive feedback. I'm glad we worked on this today. I can see you're really trying. Comments like that go a long way. Stay open to feedback. So, maybe your kid doesn't like how you're reading the script. Maybe you're going too quickly. Maybe you're not going quickly enough. Talk about it. What worked for them? What didn't work for them? Work as a team to try to find some rhythm to it. And then this will sound a little counterintuitive too, but don't focus on pain as the outcome. So remember that we're trying to wind down the whole nervous system. And this is a biopsychosocial problem. So they may benefit, they may feel more relaxed, less stressed. They may really enjoy the social connection between the two of you while you do this. They may feel well supported. They may feel that this is a good plan, and all of those things will help them to feel better. So we don't want to sort of practice something and then be like, do you feel better now? Because probably your answer will be no. But you might find that they're like, that was okay, or I'd be willing to do that again. And that's the idea. We're trying to grow the skill. So in addition to practicing the relaxation response, those dimmer switch strategies, I want to share with you some ideas about some of the circuit breakers or the habit cycles that you can think about trying to break. And when I talk to parents about these, I refer to them as sort of first and second intuitions, because our first intuition comes from our gut feeling as a parent about how we want to help support our kids. So our first intuition comes from how we take care of scraped knees or strep throats or even a broken bone at first, those acute kinds of injuries. This idea, for example, one habit cycle could be, I need to let my child rest more so they can recover from their symptoms. Or I need to ask my child about their symptoms throughout the day so they know how much I care for them. And this happens a lot for parents, because if your kid's been hurting for a long time, then for sure as a parent, you're worried. That checks, that makes total sense. But when we start asking our kids a lot, like when they wake up, how do you feel? Or after they eat lunch, how's your pain? Or when they get home from school, how was your pain today? All of those questions, ping them to pay attention to the pain. And when we're paying more attention to it and we're focused on it, we're more sensitive to it and we feel it more. So that idea of checking in about pain, not helpful, turns out. Or the last one, the more I do for my child, the faster they will recover. It's very common and normal behavior for parents to do what they can to sort of dote on their child to help them get better. But sometimes that backfires in a long-term recovery. So these are some second intuitions. These are sort of some things to consider that I invite you to think about if there are places that you might adopt some new responses to your kids. So for example, I can help my child's recovery by supporting a daily routine and encouraging some activity even when there's pain or discomfort. So once you know that the pain is hurting for sure, but not harming your child, once you get that green light, and most chronic pain falls under that umbrella, then it's safe and helpful to move forward with some daily routines and activity. And that cycle will help to reverse the experience of persistent pain. So we're really sort of putting the whole thing in reverse. Or the next one, I need to stay focused on talking to my child about non-medical things and break my habit of checking in about pain or discomfort. So this is the bite your tongue a little bit phenomenon. When you want to ask, when the question's there on the tip of your tongue, see if you can pause and check in about something else. Who'd you sit with at lunch today? Or you know, what's one interesting thing you did in your day today, or an interesting dream you had last night. But try not to ask. The less you ask, the better. One caveat I'll say, if you've been in the habit of checking in or asking a lot about persistent pain, you might want to tell your child that you're going to stop asking so they don't think it's weird, so they don't think that you've forgotten about them or that you don't love them. It's not that. It's just if you can move away from that habit, it will pain them less to think about it. So you might say, I learned it might not be so helpful to ask you all the time about how you're feeling. Definitely feel free to tell me if you're not feeling great, but I'm not going to check in with you. So just let them know that there's going to be a shift. And then the last one, when I find opportunities to take a step back, my child will learn that they are able to do more. So that's the idea of the self-efficacy. We really want them to see themselves as capable, which of course makes sense. But sometimes we fall into these traps where little things have shifted, like, I don't know, maybe your child used to have to make their bed in the morning, but now you're doing that. Or they used to prep their lunch before they went to school, and now you're doing that. So little things like that. See if you can get back to some of the routines that were in place and break some of the habit cycles that have seeped in since chronic pain has been there. I want to share with you a quick video that is just a little bit about a parent perspective. I'm going to talk in a minute about the comfortability program as a resource. And this is a parent that did the program. And it's really about sort of learning this idea that pain is biopsychosocial and understanding what this treatment approach looks like. And my whole focus, like what I'm really passionate about, is trying to get this information out to people downstream before things get really difficult. And because you'll hear from this parent what this perspective can be like. So let me go ahead and share this with you.
The one thing that I wish I knew when Joe was first diagnosed with some type of, pain disorder or chronic pain is that the pain is real. It's not just, it wasn't just in his head. It was a real disorder with hypersensitive nerves and pain signals being sent to areas of injury where there was no longer an injury. And if I understood that, then I would have known better what type of providers Joe needed, and I would have sought them out earlier than I did. And if I had known that from the very beginning, I think Joe would have done much, much better early. And he wouldn't have gotten to the point where he was in a wheelchair, non-responsive, because it just made the process much more difficult and much longer. And I also wish I knew at the beginning that there was a light at the end of the tunnel and that Joe would get better, because he did. At the end of the tunnel.
Oops, sorry.
And that.
Okay, so, and then hold on one sec. Back. Okay, there we go. There we go. So we see kids with all sorts of persistent pain, parents that have been on a really harrowing journey, like that mom described, or kids that are just struggling with daily headaches or ongoing abdominal pain. Can really be across the spectrum in terms of how pain impacts kids. But the sooner, really for all of the kids that are struggling with ongoing symptoms, the sooner they understand this sort of the biopsychosocial piece of it, that the pain itself is modulated by the brain, and that there's quite a lot we can bring from psychology into the picture, the better things are. So let me just run through a couple of resources, and then I'm happy to take some questions. The program I direct is called the Comfortability Program. And just to sort of, I'm going to show you the website actually in just a second here, but just to give you a sense, the program is all focused on sharing resources to help kids with persistent pain and their parents and caregivers. One big part of the program are workshops that we run. We run them at Boston Children's Hospital. It's a one-day intensive workshop for kids with persistent pain, ages 10 to 17, and their parents. But they're run throughout the country. Actually, they're run in the US and Canada and Australia. They're run all over the place. And so if you're not local to the Boston area, you might be able to find one local to you. And on the website, in addition to sort of figuring out where you can do these crash course workshops and learning how to manage persistent pain, lots of information on the website as well, including relaxation and mindfulness exercises that are guided, how-to videos. So we talked about the parent-supported relaxation video, but there's also a video in like, how do you talk to your kid when you feel like they've lost hope or that they don't want to engage in the exercises, daily exercise or the relaxation practice, and you feel like you're really stuck. That's what the reflective listening is about. There's a video on there about how to make an effective plan with your school, and lots of coping stories on there as well. The other thing I'll mention is that we do free online health chats every month. We alternate between kids and parents. And so this is an opportunity to connect with a psychologist. And we also have patients and parents or caregivers on the chats as well. So that means on a teen chat, we've got a teen who's walked this walk with a lived experience on the chat, as well as a psychologist and any of the teens that sign up. And similarly, on the parent chat, we have a parent with lived experience who joins us as well. And then I'll also share that we have a newsletter that goes out, it says monthly, it's not quite monthly, maybe every other month, with lots of resources and things like that on it as well. And you'll see in the slides after our talk that these are 3 other resources that I can speak very highly about, all evidence-based. One is called WebMap Mobile. This is a free downloadable app that teaches a lot of pain education and CBT, or cognitive behavioral therapy basics. So that can be a helpful tool. There's a fun website called Pain Bites from Australia that has a lot of videos about teens talking about pain coping. So it's a really nice resource, easy to access. And then finally, I'll just mention there's a great program in LA called Creative Healing for Youth with Pain. And even though they're based in LA, much of what they do is virtual. So they do a lot of supportive art projects and support groups and have lots of great resources. And that's for kids and young adults all the way up through age 25, I think. So that's a great resource as well. Okay, a few quick take-home messages, and then we'll see if there's some questions. Pain is a biopsychosocial problem, and pediatric pain is common and it's treatable. Very important. Most kids get better with multidisciplinary outpatient services, including cognitive behavioral therapy. And I highlight the outpatient side because the vast majority of the kids we see do better with that model. But remember I mentioned at the beginning, there's like 5% of kids who are really disabled. I also want to mention that those kids might need what's called an intensive rehabilitation program. So these are programs like where kids go for the whole day and they learn how to start moving again, and they get intensive psychological support, and they might go every day for 4 weeks to a program like this. Boston Children's has one of these programs, but they also exist at other hospitals and institutions as well. Persistent pain can be very confusing. Education and skills-based training and how to support a child are essential. You have to know what it is, how it works, and what to do about it. Those are necessary. And then the other part is you have to be able to do it. And so lots of resources for parents and caregivers available through the Comfortability. That's one great resource, and also some others as well. So I think we have a few minutes now for questions.
Yes, Rachel, thank you so much for a wonderful talk. So we've been looking at the questions and maybe can throw a couple out to you. The first one is pain that happens episodically over a period of time longer than 3 months still considered chronic pain?
Good question. Yes, it is. So like headaches would fall into that category. You might not have a headache every single day, but we call that recurrent pain, and it is a type of persistent pain. Mhm.
So another one is, can pain which originates from a chronic illness, such as an acquired autoimmune disorder, be treated with techniques such as CBT, or can the brain only be retrained to reduce neuroplastic pain?
Also a great question. Um, so yes, we use all of these skills and tools and approaches for chronic pain, but pain of any sort can get better with these. So we also use the same toolbox approach for acute pain sometimes. Kids with sickle cell disease, for example, they have episodes of acute pain and they sometimes have chronic pain, but we use the same kinds of strategies because think about even acute pain is biopsychosocial. So even if there's a driver of the pain, like an autoimmune disease or another disease or an illness process that's still unfolding, there's a lot we can still do from the psychology and the social impact area, those bubbles, that will reduce how acutely somebody experiences that pain. So this is why we look across all areas all the time. And by the way, I should say we use these same strategies in oncology for kids with cancer-related pain. So it's not, we never make the distinction, for example, is it real pain or is it disease-related pain, real pain or chronic pain that doesn't have an ongoing driver? It kind of doesn't matter. We use a lot of the same tools across both.
We also have a question from the parent of a 6-year-old commenting that they've tried many strategies and many of the tips, but it's especially challenging given her younger age, and wonders if you have specific resources, programs, or tips for younger kids.
Yeah, it's younger kids, need a lot more hand holding, right? Like they are going to learn from their parents how to do these things or from their caregivers. One of the things that's really important with little kids, like if I'm doing relaxation with a 6-year-old, we might be working on 2 minutes of deep breathing together. And that might be it. You're never going to get a 6-year-old to sit for a 15-minute guided imagery, or it's rare, I should say. There's a really fun, great resource. I didn't put it up, but I want to include it, called Imagine Action, which is based in some self-hypnosis. You can find it through Stanford. If you type in Imagine Action, great resources that some of them work really beautifully for young kids, and it gives them these cues about how to use their imagination to help themselves feel better. So I think that's a terrific resource. I also have some specific recommendations for young kids in my book as well. So you might find some good recommendations there.
I think that's the last of the questions, unless anyone else has one in the next minute. Somebody does. The question is, how can we strike a balance between encouraging a child to return to school despite chronic pain and not increasing their stress and anxiety?
Yeah, this is where school plans come in. Like school is tough. I hear you on that. I think the best glide path forward is to start really small. I'd rather start somewhere where a kid says, yeah, I could be in class for 15 minutes. Like that's doable. But I can't be there the whole day, right? Like that feels insurmountable. And what happens is over time, kids learn from their experience that they can be successful. A metaphor I like to use for sort of the going back to school is like if you had a swimming pool and you jumped in the water and it was freezing cold, and you got out again and toweled off and dried off and got warm, and then you jumped back in later, it would still feel freezing cold. And getting back to school can kind of be like that. If you've been out for a while and you feel like you can't do it and you get thrown back into it, it can be freezing cold and really uncomfortable. But if you get out and then you don't go back for a while, every time you go back, it's hard. I'd rather kids get in start to learn how to swim around in the water a little bit, get warmed up in there, and then over time you can sort of grow the amount of time that they're in the pool. So it's really about striking that balance. It has to be done in partnership with the school, and probably with some of your providers as well, and a plan made in conjunction with kids or teens.
So we have time for one last question. I will tell you that you're getting a lot of positive feedback about how informative and clarifying and reassurance this was. So thank you for that
Oh, good.
feedback. But we have one last question, which is sort of a combined question, which is, how do you know when to stop looking for a physical cause? And in conjunction with that, when do you choose to move away from the pain meds?
Yeah, gosh, I wish there was a one size fits all for this. I think working with a medical provider that you trust is very important. And what we know is, like, over time, the more tests, the more procedures, the more sort of assessments that you get, if you keep looking and keep looking and keep looking, you might find something, but it doesn't necessarily mean that that's even what's driving the pain. So I think working with somebody that really understands persistent pain, building a trusting relationship. And I think when you get the green light where they say it still hurts, but it's safe to go about this rehabilitative kind of model, then you as parents have to anchor yourself in this. I will say, when parents have this lurking doubt or worry that something's being missed, and they're sending mixed messages to their kids, like, yeah, let's do this rehabilitative kind of model, this multidisciplinary approach, but also let's go get third, fourth, fifth opinions over here. Kids understand that that means we're actually not feeling strong and sturdy in our belief that we can move forward. So I would just encourage parents to sort of check how you're thinking about it, think about what you're communicating, work with providers that you trust, and know that it's gonna feel not quite right. Like, I hear that a lot from parents, like, it feels like we should be able to fix this problem and then go back to the multidisciplinary model, but it's gonna feel like, are we sure? Are we sure this is quite right? And if it feels that way, you might be moving in the right direction. So, so working sort of in with a trusting medical provider, but then also recognizing that some of that uneasiness is very, very common.
Well, thank you, Dr. Coakley, for a wonderful presentation. It was really helpful to
You're
us on
welcome.
our team, and I'm sure to many of the participants. So thank you.
You're welcome. Delightful to be here. I appreciate you having me.